Mega learning, YouTube. Okay, just to be sure that mega learning, yes, I think we're right now. YouTube, mega learning, yes, okay, now we are recording, we are on YouTube, and ladies and gentlemen, we are so delighted tonight to have this exceptional webinar for MEGA Online Anesthesiology course. This webinar in the presence of the elite group of Dr. Yasser Zaghloul and Professor Medha Chalabi and Dr. Haitham Al-Jamil. I can't praise them enough, I'm sorry, and we have one of the top figures to be a moderator tonight, Dr. Muhammad Mustafa. Dr. Muhammad Mustafa is a role model consultant anesthetist in UK. He graduated from Benha University in Egypt, and he moved his way to the top career. Now he is a consultant anesthetist in North Cumbria Integrated Care Foundation Trust in UK, and he is the lead of the regional anesthesia surface and acute pain consultant in UK. You know the Egyptians, when they go for that road, they don't stop, and nothing stops their career till they reach the top of the pyramid of the career. Dr. Muhammad Mustafa is honoring us tonight by his presence and going to lead the webinar, and God bless the speakers for his questions, because he is very knowledgeable and very kind for taking this webinar tonight. Dr. Mustafa is all yours. Thank you.
Oh, thank you very much, Dr. Saad. Thank you. It's too much pressure on me now. However, good evening, everyone. It's 7 p.m. in Cairo time, and it's one of these Sundays which we owe a lot of anesthetists around the world now, I believe, used to convene and join in this fantastic, really, platform of learning, engaging, and interacting with top-class speakers and faculties who are really used to spread their knowledge and experience among us. Just as Dr. Saad mentioned, it's just to remind you all that we are available on different social media platforms. We are available on Facebook, in Twitter, and also the super Dr. Saad, he keep uploading the lectures on a YouTube channel. So don't forget to visit the channel. Also, don't forget to visit the fantastic free website, which offers a diverse range of free training materials, articles, and videos. So it's my pleasure for tonight to be, as for the first time, to be as a moderator. I hope I will doing well. And I'm having three speakers. Two of them are based in the United Arab Emirates, and it's my lovely country where I used to be raised there in Alain. And I'm super jealous about both of them being there. And the third speaker, actually, he is around, I would say, 90 miles above me now. It's just not above, just north of where I'm based now. And as Dr. Saad mentioned, my name is Mohammed. I'm Mohammed Mustafa Mohammed. I'm a consultant anesthetist in the UK now, and I will be with you all tonight. Right. So we're starting with the first lecture for tonight, and I have a real figure, Dr. Yasser Zaghloul. I personally enjoy listening him to a lot of other lectures. I hope I will meet him in person on one of my visits to Emirates, either Dubai or Abu Dhabi. He's a senior consultant in anesthesia and ICU director of Abu Dhabi Anesthesia Club, Sheikh Khalifa Medical City, Abu Dhabi, United Arab Emirates. He's really a talented speaker, and he keeps enriching us with a lot of really hot topics, which is extremely fundamental for every anesthetist to know more about. And tonight, he is teaching us about heart failure in non-cardiac surgery patients. And we all know that heart failure is a deadly syndrome affecting at least 2 to 3% of the population, especially in the prevalence of the elderly. And patients with heart failure undergoing either elective or emergency non-cardiac surgery in modern surgical setting have a substantial mortality risk. So it's one of these really dark areas, which is any anesthetist will be really getting worried when facing such patients. So I will keep you entertained with Dr. Yasser for tonight, and I'm sure 100% I will be personally learn from a lot from him, and shed a lot of light on this hot topic. So it's over to you, Dr. Yasser.
Okay, thank you so much, Muhammad Mustafa, and thank you for Saad Mahdi for this chance to present my talk. And as you see, the title is a little bit difficult, heart failure in non-cardiac surgery patients. Anyway, here we can see the overview of my lectures, short introduction, what is the definitions, type, and the stages of heart failure, the essential for anesthesiologists, not in too much details, the general management of heart failure as a perioperative risk factors, everybody is aware about that, and the perioperative anesthesia concern if the patient coming with acute or chronic or compensated or decompensated heart failure, then we will talk shortly about some types of cardiomyopathy and heart failure. So first, I am not a cardiologist. Heart failure is a major issue. As you can see, more than 7 journals every month talking about the heart failure only. It is a major subspecialty in cardiology in general. But again, I have to select the information or the knowledge which is essential for every anesthesiologist. One of the recent publication about the European Society of Cardiology about the guidelines, diagnosis, treatment of acute and chronic heart failure. And I got many informations from these articles, and it is well written. And I advise everybody interested in heart failure to read this article. Generally, in United States, the patient with heart failure more than 20 years is about 60 million. And every year they diagnosed 1 million of new patients with heart failure. And despite the progress in medicine and the technology and in pharmacology, still the mortality rate is high in all age group and both sex. Generally, the annual cost is $30 billion per year, and it is the most common reason for hospital admission for patients more than 65 years. So it is a major medical problem. Mortality is still high from 20 to 25% in patients diagnosed with heart failure. And heart failure is recently diagnosed as a clinical syndrome, and you have symptoms like shortness of breath or easy fatigability, and you have the signs of increased jugular venous pressure, pulmonary edema, and peripheral edema. And at the same time, we have structural or functional abnormality in the myocardium, and we will explain some difference now about the structure and functional abnormalities. And of course, the intracardiac pressures will be high and inadequate cardiac output, which affecting all the organs of the body and will limit the exercise of the patient. The most simple classification of the heart failure or systolic and diastolic. This is the old one. In systolic one, as you see, the heart is thin, and diastolic, the heart is thick, but in both situations, the blood pumped by blood is limited, and the contraction in the diastolic dysfunctions is normal, but still the blood pumped is less. Now come to the recent classification. We have 3 types. Reduced ejection fraction, this is less than 40%. Mild reduction in the ejection fraction between 41 to 49, and preserved ejection fraction more than 50%. a little bit strange how to have patient with heart failure and preserved ejection fraction. We will explain this very soon. Actually, because we have a lot of chronic medical problem which affecting the heart, diabetes, hypertension, COPD, chronic kidney disease, obesity, anemia, long-term depression, all these lead to some changes in the heart, impairment in the feeling and relaxation, atrial dysfunction, dynamic mitral regurg, vascular dysfunctions, and pulmonary hypertension. So despite there is no structural damage of the myocardium, but still we have functional abnormality. That's why we have patient with heart failure and preserved ejection fraction or more than 50%. And of course, if you have more clinical problems, the possibility will be high. Now, I am discussing some case happened with me. This patient is 64 years old, hypertensive, diabetic, dyslipidemia, obese, mild anemia, hemoglobin 11.2. And he is in enalapril, oral hypoglycemic, and statin. This patient coming for bilateral total knee replacement, and it was done with combined spinal epidural, propofol TCI sedation guided by bispectral index. I used phenylephrine to maintain MAB more than 65 or 70, surgery 4 hours, and the blood loss at the end is 400, and he received Ringer lactate 1.5 liter. So is this patient at risk for perioperative heart failure? I can hear you, most of you may be yes, but yes, why? We have now to see. Now we have what is the cardiac complications which occurs with major non-cardiac surgery. Actually, it depends on the 4 factors: preoperative, surgery, anesthesia, and the post-operative. Preoperative, as you see, patient coronary heart disease, chronic kidney disease, hypertension, heart failure, atrial fibrillation, recent stroke or MI, coming for emergency surgery. Surgery and anesthesia, we are aware they have a lot of systemic changes due to the sympathetic nervous stimulation, bleeding, inflammation, cardiovascular instability, hypoxemia, hypothermia. Post-operative factors still risk factors for cardiac complication due to the hemodynamic instability, desaturation, pain, bleeding. And at the same time, most of the cardiovascular drugs is stopped preoperatively. This leads to the mismatch between oxygen supply and the demand, and there is some possibility of coronary artery thrombosis and arrhythmia. So the end result is myocardial ischemia and infarctions, and this may extend to the heart failure and the cardiac arrest. So remember this slide, well, the preoperative, post-operative anesthesia and the surgery, this is causing most of the problem in patient coming for non-cardiac surgery. How can I know the severity of heart failure? If some patient coming for me and he told I have heart failure, what the stages, what is the severity? We have 4 stages. Stage 1, or stage A, the patient don't have actual heart disease. He has the other comorbidities. That's why the treatment is directed to the control of blood pressure, sugar, reduction of the body weight, and giving statin for metabolic syndrome. Stage B, the patient has already heart disease, maybe all the MI or ischemia, left ventricular failure, reduction in the ejection fraction, valve disease. At this situation, you are giving ECE inhibitors for all patients. You may need to give aspirin. Beta blocker is indicated in some patients, plus or minus statin according to the cholesterol and the lipid profile. Stage C, this is the patient already has signs and the symptoms of heart failure. So shortness of breath, fatigue, exercise intolerance, maybe renal impairment as well. So you have to add another medication like diuretics, aldosterone antagonist, digoxin. Patient may need pacemaker, and it is indicated ICD and the pacemaker in patient with ejection fraction less than 30%. Actually, this is a little bit old recommendation in 2017, as we will see now the new recommendations if it is less than 35. So give a little bit higher safety margin. Stage D, this is the most worst one. The patient is not responding to the medical treatment and he may need long-term hospitalization. And this is potentially for heart transplantation if available in some countries. So this is the main 4 stages of heart failure. According to the new guidelines, they added 2 new drugs for the management. Everybody is aware about beta blocker, ACE inhibitor, statin, digoxin, diuretic. But there is no new group of the drug added to the heart failure patient with reduction in the ejection fraction. The first one, dabigloflozin, this is an sodium glucose co-transporter inhibitor used in the diabetes type 2. The second medication is Versigat, which is cyclase stimulator and enhances the GMP pathway. And the second one is indicated in patient with NIHA group from 2, 3, or 4, not responding for the conventional treatment. You give all the medication to control the heart failure, but in this situation, patient is not responding, you may add Versigat. Regarding the first medication, the dapagliflozin, this is the glucose, sodium glucose co-transporter inhibitors. The main effect, everybody is asking how the anti-diabetic effect may improve the heart failure. The main issue that for the transporter inhibitors is the reduction of the absorption of sodium and glucose by tubules from the kidney. So increase the sodium and glucose excretion, decrease the burden and the load of the kidney. So the end result after many changes improves the ventricular functions. In the same time, the kidney, when it is loaded by glucose, the production of erythropoietin is reduced. When the transporter inhibitor is used and there is more excretion of glucose, the EPO-producing fibroblast recover its functions, so erythropoietin will be produced more and it will be increased the hematocrit. In short, increase the sodium and glucose excretions, improve the ventricular function. That's why the transporter inhibitors added to the patient with chronic heart failure with reduction in the ejection fraction. I can hear many asking that this is in patient with diabetic. Can I use it in non-diabetic patient? Actually, yes, because it is not reducing the blood sugar. It is not causing hypoglycemia. It improves the renal tubules function regarding sodium load and glucose load. And in this recent study or meta-analysis, they found that also when you are using the transporter inhibitors, in case of non-diabetic patients, it improves the metabolic parameters with reduction of the body weight and the blood pressure, again, in non-diabetic patients. Regarding the Versigat, how it improves the functions of the heart, generally in patients with heart failure, we have endothelial dysfunctions, oxidative stress, inflammation. This impairs the nitric oxide. So we have GMP deficiency, vascular dysfunctions, and myocardial dysfunctions. Once the patient has Versigat, this will enhance the GMP pathway and increase the GMP concentration. So it will reduce the left ventricular hypertrophy, causing vasodilatation, and it increase the renal blood flow. So we understand now why these 2 medications is added to the patient with heart failure. Beta blocker also is important medication and should be used in all patients with heart failure and reduce the ejection fraction, but it should be initiated in small doses gradually. And if the patient is not in beta blocker preoperative, it should be started at least 1 week before the elective surgery. And of course, it is contraindicated in acute decompensation, heart block, and bronchial asthma. Another option in the treatment of heart failure is resynchronization therapy. And as I mentioned, recommended in ejection fraction less than 35% and prolongation QRS more than 150 seconds and left bundle branch block. So now we understand the general management or treatment of heart failure. Heart failure as a preoperative risk factor is well known since more than 45 years when Goldman implanted his risk index and he put heart failure in the top of all the risk factors. You can see MI, non-serious rhythm, age, emergency, but whatever the heart failure is the most important risk factor. Also, Lee's index puts the same congestive heart failure on top of the risk factor for patient coming for non-cardiac surgery, in addition to the ischemic heart disease, transient ischemic attack, and the stroke. Patient needed insulin for diabetes, or there is renal impairment. And of course, decompensated heart failure is a absolute contraindication for elective surgery. If you have a patient with decompensated heart failure coming for emergency surgery, we will discuss it very soon. Now, if the patient coming with heart failure for non-cardiac surgery, whatever the heart failure controlled or not controlled, what is the outcomes? This recent study reviewed more than 21 million patients. Can you imagine all the file of more than 21 million patients coming for non-cardiac surgery, more than 18 years with review? They found heart failure in about 5% of the patients. This means about 1 million. What is strange in this study? The patient who has acute heart failure, this has the highest mortality. That means the patient don't have chronic heart failure before. Like, as you see, acute heart failure is the higher mortality, 8%. Chronic heart failure and decompensated to acute, less mortality. Chronic heart failure only without development of acute heart failure, the mortality is less. Intermediate heart failure, this means maybe mixed with other problem like pulmonary embolism, the same one. Adjusted odds ratio is 2. In short, acute new heart failure during the pre-operative period is the highest mortality, and we have to explain it, of course. Now, if the patient has myocardial injury and developed congestive heart failure, the mortality is high, is about 9.4%. And the myocardial injury, we mean ischemia, infarction, heart failure, serious arrhythmia, cardiac arrest, or cardiac death. These 5 points for the myocardial injuries in non-cardiac surgery. And again, we have to stress the congestive heart failure with myocardial injury has high mortality up to 10%. They found here the main problem in the patient is the oxygen supply demand mismatch, not thrombosis. And as I explained before, the hemodynamic changes or hypoxemia or arrhythmia or anemia and the factors which may increase oxygen demand like pain, fever, shivering, agitation, and this is the main problem which may cause the ischemia and infarction. Also, if the patient has heart failure, there is high risk of post-operative acute kidney injury because of the bleeding, positive pressure, anesthesia, volume loss, and in the presence of anemia, surgical injury, all these predisposed to the acute kidney injury. The problem, again, it is maybe difficult, and the presentation is not typical like in medical patients, and as you see, the factors is completely different than the medical patients. That's why it may be missed or not diagnosed in good time. What is our anesthesia concern for patient coming with heart failure? First, I know there is 2 lectures now about enhancing recovery after surgery, but I like to name it improving recovery before surgery. This means the proper optimization and intervention which avoids the intra and the post-operative complication or any problem. Anyway, any patient of heart failure, it is logic to ask the cardiology consultation and evaluation, continuation of all medication, including the day of surgery, except the anticoagulant or maybe C inhibitors in some patients. But generally, you have to continue all the medication. If you have to stop some medication, this will be discussed in another lecture. Optimization of all the comorbidities in the patient, especially blood pressure, hypertension, diabetes, COPD, and anemia. If the patient at higher risk, you have to discuss it with the patient and in the family. And even simple intervention can improve the outcome, like reduction of the body weight and the controlling of the chronic pain before surgery and exercise. For exercise, for example, if the patient doing exercise for 2.5 hours per week, this means about 30 minutes for 5 days per week, you can see the lot of improvement in the general functions. Improve the respiratory muscle, increase cardiac output, decrease resting heart rate, decrease sympathetic tone, increase vagal tone, improvement in the endothelial functions, decrease inflammation, decrease insulin resistance. Anyways, it's something is very simple and can improve the patient functional capacity before elective surgery. Anemia is a major issue also, and as you know, it is defined by the World Health Organization, less than 30 in man and less than 12 in woman. And it is recommended all patients with major surgery and expected blood loss than 500 to investigate and to treat the anemia. And usually the recommended target to be more than 130 in all male and female patients. This, as you see, it is a consensus about the international statement by many authors from different countries. So it is not a personal opinion regarding the essential management and improvement of anemia in patients in general and specifically in heart failure. And I will come back to the anemia again with patients with heart failure. Patient should be assisted for echo. BNP should be assisted as well because it is prognostic. Patient coming with high BNP, higher mortality or higher morbidity or higher risk of decompensated heart failure. And if the heart failure is newly diagnosed, it should be treated for 3 months before coming to the elective surgery. Again, for emergency surgery, we are coming for it. This is the standard preoperative treatment in patients coming with heart failure according to the European Heart Journals 2 months before. BNP or pro-BNP, ECG, echo, chest X-ray, and electrolytes, blood count, thyroid functions, glucose, lipids, and iron status, and test this is transferrin saturation. Again, this to see the iron store and if this patient is liable for anemia or no. So this is the standard for heart failure patient to investigate preoperatively. Something is very strange in medical patients. The most common factor for decompensation of heart failure is the anemia. As you can see, if hemoglobin than 10.9 is responsible about 36 or maybe 64% of decompensation of heart failure. Other ischemia, this improper food intake, this patient high sugar or lipids or high cholesterol, valvular dysfunctions, infection, drugs, starting new drugs like calcium channel blockers or beta blockers have negative inotropic effects, so it may decompensate the heart failure. And may be important for us, the blood pressure more than 140/90 or poorly controlled diabetes also is a risk factor. This is in medical patient, not in surgical patient. But of course, we have to consider it in our patient coming for anesthesia. That's why the target should be more than 130 if the patient coming for major surgery to limit the blood transfusion. Another recent article about the preoperative anemia and the myocardial injury after non-cardiac surgery and divided the patient to 3 groups, hemoglobin more than 30, the myocardial injury about 14%. From 11 to 13, it is 21%, moderate to severe anemia, and it is defined as hemoglobin less than 11. The myocardial injury is about 30%. 1/3 of the patient coming for non-cardiac surgery with hemoglobin less than 11 may develop ischemia, infarction, arrhythmia, heart failure, cardiac arrest, or even cardiac death. So we should consider anemia seriously, not just a figure or number. Now, the more explanation about the anemia and the effect in heart failure. This is the normal relationship between oxygen delivery and oxygen consumption in normal person. The hemoglobin from 13 to 7, critical oxygen delivery. This means anaerobic metabolism and reduction of oxygen delivery occur at hemoglobin 7. This is in normal person. If the patient has heart failure, this shift to the right, and the critical oxygen delivery may occur at 8 or 9. Heart failure plus anemia may occur at 9, at 10, and multi-organ failure with heart failure and anemia may occur more than 10 even. So patient coming with heart failure and anemia, very critical oxygen delivery can occur at high hemoglobin level that you may consider it is okay, or the patient's compensated 8 or 9, but he may develop anaerobic metabolism at the level of 9 or 10. Another important issue for hemoglobin and RBCs, you may ask why I am giving blood. I'm giving blood to increase the oxygen delivery. No, it is not the only issues. Everybody of us forgets the other important physiological factors of RBCs and hemoglobin. Hemoglobin is the primary oxygen sensor and the modulator involved in nitric oxide activation and deactivation. That means it is important to maintain the vascular tone. Now, if the patient is coming for any surgery and occurs interoperative hypotension for any reason, hemorrhagic shock, septic shock, hypovolemic shock, and you are starting to give vasopressor, nor-epi, or phenylephrine, or vasopressin, or whatever, and the patient is not responding simply because he is anemic. You don't have the hemoglobin, which is essential for oxygen sensor and modulator of nitric oxide to maintain the vascular tone. Enough for anemia now. Acute post-operative pain is another problem, may cause myocardial injury, and they found that troponin increased in about 5% with myocardial injury in around 3,000 patients within 72 hours, simply because of poor pain control. And this because the significant sympathetic stimulation and side effect of uncontrolled pain, which may increase the myocardial work, hypercoagulation status, may cause Dvt, pulmonary embolism. In short, poor control of pain within 72 hours, causing myocardial injury in 4.5% of the patient. Interoperative hypotension with drop more than 50 millimeter mercury increased 20-fold risk in the clinically significant perioperative MI. And MI, if not diagnosed, not detected, will progress for heart failure and even for cardiac arrest. So if you have a patient coming for surgery, which type of hemodynamic monitoring? If low-risk patient and low-risk surgery, basic monitoring. High-risk patient or surgery, you need stroke volume variation monitoring to check for fluid responsiveness. High-risk patient, you should have more sophisticated, and you need to check for the cardiac output, systemic vascular resistance, and cardiac end. Simply to know this hypotension due to the hypovolemia or vasodilatation or poor cardiac output or poor myocardial. That's why you have to monitor your patients well. Patient with heart failure for urgent non-cardiac surgery, what you can do? Actually, you have to ask yourself first, this decompensated heart failure due to the acute coronary syndrome or no? If it is due to the acute coronary syndrome, the patient should go to the acute coronary syndrome pathway under cardiology care. See the patient for heart failure. You may have 3 categories: patient stable heart failure, new heart failure, or decompensated refractory heart failure. Of course, stable heart failure with good functional capacity, you can go ahead for surgery without minimal problem. If you stabilize the patient within 6 to 24 hours stable, so you can go for this pathway, stable pathway. Unstable, you have to continue the heart failure therapy. If the patient still has heart failure and has still indicated for surgery, you have to consider non-surgical management. I can hear you, all of you asking if the patient poor functional capacity or still heart failure and surgery is indicated, should be done. What we can do? See this patient. This one of my patient, 57 years old, came to ER with chest pain, shortness of breath, MI, VF, cardiac arrest, CPR, multiple DC shock, taking for cath lab, and they found left coronary artery occlusion. Stent was done. After stent, the patient in ventilator, echo, severe systolic dysfunction, infralateral hypokinesia, apical kinesia, and ejection fraction in 25%. This is the first day in the hospital. We are not involved yet. But in day 4, the patient still in severe heart failure, in 4 medication, levosimendan, adrenaline, dobutamine, and vasopressin, and he developed respiratory distress syndrome needing nitric oxide, renal failure and renal replacement therapy, febrile increasing sepsis marker, abdominal compartment syndrome, and he was diagnosed septic peritonitis for urgent laparotomy. Is this patient who is multi-organ failure is fit of anesthesia? Of course, is not fit, but there is some surgery should be done. And it was done actually. This is a patient come for OR. You can see he's in nitric oxide 10 parts per million and is 70% oxygen and the beep of 9 and saturation is 93. Difficult to ventilate. Peak airway pressure is 35 and CO2 is 75. Again, because of the abdomen is very distended, temperature is very high, is 40. That's why we pushed him to the OR, and CVB is 30. Maybe it is not accurate because of the ARDS, high beep, and abdominal compartment syndrome. Anyway, they operated this patient, and they found about 2 meters of the small bowel gangrenous, and it needed resection and anastomosis. This because, of course, the patient is hypotensive for a long time and the effect of vasoactive medications. Anyway, it was done resection, anastomosis, and decompression of the abdomen because of the abdominal compartment syndrome, and it was closed later on. Again, I can hear all of you. What is the progress of this patient? Maybe a little bit away from our lecture, but I will tell you. The patient has tracheostomy after 3 weeks, discharge from the hospital after recovery and weaning from the ventilator after 52 days. Hospital discharge at day 93 and with ejection fraction was around 35%. And actually this patient came after 7 months for repair of the incisional area, and all his organ is working well except the myocardium and this poor ejection fraction 35, and he was in antifailure and double platelet therapy for the stent. So the lesson from this one, never give up. If I win, never lose. I either win or learn. Anyway, if you have some intraoperative heart failure, you have 3 categories of patient. Systolic dysfunction, reduction in the cardiac output and congestion. Diastolic dysfunctions, the patient may be hypertensive again. He has pulmonary edema and congestion or volume overload. For the first one, you have to use dobutamine, milrinone, plus or minus norepinephrine to maintain the map. Diastolic, of course, you have to use vasodilator to reduce the blood pressure to improve the diastolic functions. And if the patient is volume overloaded, loop diuretic like furosemide or Lasix. The new in the loop diuretics that what is named hyperdiuresis. Hyperdiuresis means you are giving the patient hypertonic saline is around 150 ml of 3% plus furosemide maybe 40 or 80 milligram. And the concept behind that, the patient with heart failure may have hypochloremia. Hypochloremia causes sodium retention and may aggravate the heart failure. And recently in patient coming with acute decompensated heart failure, when hyperdiuresis is used, it reduces all the mortality, increase the total urine output and the sodium excretion, shorter hospital stay, and decrease the heart failure readmission. Despite of that, it is low to the moderate recommendations, but I think it is good option in the surgical patient to use the hypertonic saline. Most of the surgical patients is relatively hypovolemic, and if you give hypertonic saline, may correct the hypovolemia in the same time. Now we are told that in patients with systolic dysfunction, you may use milrinone or dobutamine, which is best. Actually, in this recent study, they found both of them is the same, but maybe the side effects like stroke, transient ischemic attack, or renal event is a little bit higher with dobutamine, occurs in 54%. But statistically, it is not significant. So if you have milrinone, it's okay. If you don't have it, dobutamine is okay for patient with systolic dysfunction. Now we come back to the orthopedic patient who has bilateral total knee replacement, and I asked, is this patient at risk for perioperative heart failure or no? This is the progress of patient in recovery room. He was awake, no pain in epidural infusion, ropivacaine 0.1 plus fentanyl 2 mic per ml, 6 ml per hour. But unfortunately, after 35 minutes, he developed shortness of breath, dyspnea, become hypotensive, tachycardic, desaturated despite oxygen therapy, and the blood loss from both drains is around 550 ml. EBG, mild acidosis, VO2 is acceptable. Patient is tachypneic, so CO2 is 32, acidotic, lactate 3.4, hemoglobin dropped to 81. Preoperative, it is 11.5. Diffuse SCG changes in the ECG with BVCs, and when checked for the cardiac enzymes, there is increased CKMB, troponin, and BNP. So what happened to this patient, and what is your management? I can't hear. Okay, so of course, this blood loss causing myocardial ischemia. And again, remember the risk factors: preoperative, surgery, anesthesia, post-operative. All these oxygen supply demand mismatch due to the acute hypovolemia and the anemia, and the patient actually developed ischemia, not infarction. Maybe there is some increase in the cardiac enzyme, but he was normalized after that. So this myocardial ischemia, functional heart failure due to the anemia and the hypovolemia, and 2 units of blood were transfused for him, stabilized within 30 hours. All this is in recovery room. He didn't go yet for ICU. After that, he went to ICU. And the cardiology follow-up for 72 hours with no more cardiac event. So patient with multiple risk factor may be at risk for perioperative heart failure. Now we come to the last point in my lecture. Patient have apparently normal heart with no evidence hypertension, coronary artery disease, valvular or congenital heart disease, and he may develop heart failure. Maybe everybody is aware about the cardiomyopathy, dilated, hypertrophic, restrictive, or arrhythmogenic cardiomyopathy. But every one of that need maybe half an hour at least to talk. But actually, I am not talking about this type of cardiomyopathies. So we are talking about what? Again, remember why patient with acute heart failures had 80% mortality. Simply, we are not expecting this group of patients to develop heart failure. So which group of patients? This one, patient with chronic health problem, hypertension, diabetes, obesity, cirrhotic liver, patient with chronic kidney disease, chemotherapy, alcohol. And it may occur acute, like in patient with sepsis, post-peripartum, tachycardia or stress cardiomyopathy, neurogenic stent myocardium, which may occur with subarachnoid hemorrhage, stroke, or TPI or ECT, negative pressure pulmonary edema in patient with severe stridor and during thoracic surgery. Of course, I will not mention all. I just mention a few points about some topics. We have to differentiate between cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. And the non-cardiogenic pulmonary edema, fortunately, due to the reversible myocardial dysfunction. So it can be treated. The most common example is the neurogenic stent myocardium due to the acute brain injury. We have massive sympathetic nervous stimulation, and systemic vasoconstriction is very high, and also pulmonary vasoconstriction. The end result is pulmonary edema due to the increased permeability and increase the pulmonary capillary pressure. This is one of the examples. And of course, you have to treat the cause for this patient. Septic cardiomyopathy, due to a lot of problems, especially adrenergic receptors, down regulation. Just 3 minutes, okay? Down regulations of the mitochondria, coronary microvascular changes, and myocardial dysfunction. The end result is that the patient has left ventricular hypokinesia and ejection fraction less than 40 or 45% in 50% of the patient who are completely normal before the sepsis, no heart disease. And the management is norepinephrine to maintain MAP more than 65, and you may add vasopressin if not responding for norepi, and if cardiac dysfunctions, you may add dobutamine or epinephrine, and the recent recommendation, you may use the vasoactive drugs in peripheral vein. Diabetic cardiomyopathy also increase the mortality to 3-fold in patient coming for surgery. And this diabetic cardiomyopathy occur in 1/4 of type 1 and 1/3 of type 2 diabetic patients. What is the manifestation? Patient may have tachycardia, exercise intolerance, orthostatic hypotension, cardiovascular instability, and everybody is aware about the ischemia and the infarctions, which is silent in diabetic patients. When to expect it? We have a lot of diabetic patients every day. Patient poorly controlled, chronic hyperglycemia, patient with retinopathy and nephropathy, high incidence of cardiovascular autonomic neuropathy, and history of heart failure. Actually, it is gradual. And first, it is subclinical. After that, increase due to the denervation of the parasympathetic fibers. When parasympathetic and sympathetic denervation, we have more complication. Resting tachycardia, impaired exercise tolerance, and the more severe orthostatic hypotension. Obesity cardiomyopathy, again, we have lipotoxic heart disease, and this affecting both sides of the heart. The right side of the heart, due to the obstructive sleep apnea, pulmonary hypertension, right ventricular hypertrophy, and affecting the left side again because increase the load and the cardiac output. So right and left heart, we may have right heart failure and left heart failure, and some patients will come with biventricular failure. Maybe not common, but still a big problem in obese patients. And the higher the time or the duration of obesity, it's like more than 10 years, the higher the incidence of the obesity cardiomyopathy. And it was recommended to do preoperative echo for evaluation if the obesity more than 10 years, if the patient has suspected signs of heart failure, arrhythmia, and even if the patient coming for major surgery. Cirrhotic cardiomyopathy, we have 3 stages: reduced cardiac functions, compensatory phase, and the cardiac phase. First, the patient is hyperdynamic state, then patient tachycardia and the palpitations, then he will develop heart failure and the pulmonary edema. And the echo here, just isovolemic relaxation time increased. He has diastolic dysfunctions. He may have diastolic and systolic dysfunction. So patient with cirrhosis needed also to be evaluated for cardiac functions. Chemotherapy, patients in a lot of medication for chemotherapy, and all the or almost all the drugs used for chemotherapy in oncology has cardiomyocyte damage and heart failure. This another cardiovascular effect which may prepare for heart failure as well, like thromboembolism, arrhythmia, hypertension, ischemic heart disease, valvular disease, pericardial effusion. All these may predispose to the heart failure. Cardiomyopathy, this is the last point of my lecture. Here, the systemic review of published cases, it was found in 93 patients. Mostly it is female. Can occur with general anesthesia, neuroaxial, sedation, and in some cases not reported. Heart failure in 57% of the patient, and we may have some complication like arrhythmia, stroke, or cardiac arrest, and it can occur at all the time of anesthesia. The strange here, 58% occurs post-operative, and the highest in the first, during the surgery day 0, 37%, this is the higher. But you can see it can occur at all the stages of the anesthesia. And there is many triggering factors, maybe the most important in depth of anesthesia, intubation, extubation at very light anesthesia. If you are using exogenous catecholamine, if the patient has anaphylaxis, during electroconvulsive therapy, very high CO2, and use of ergotamine in cesarean section, cardiac arrest, spinal cord stimulation. Now,
time is running.
Summary of my lectures: perioperative heart failure, reduce the incidence of, you have to continue all the medication, reduce the incidence of the left heart failure, prevention and early management of all the factors we mentioned, which may precipitate heart failure. And heart failure may occur in some groups that I explained some of them without history of heart failure. So if you cannot explain it simply, you didn't understand it well. So did I explain it simply? I hope so. Thank you very much. I am very sorry for long time. Nobody here?
Dr. Yasser, thank you very much. This is looks like you put a lot of efforts for this presentation. A lot of efforts. Thank you very much, and a lot of clever nomenclatures and terminologies, a lot of drugs and mechanisms and all this stuff, which is so thank you very much. It's really fantastic. Thank you. I have just because of the time, I will
I know I take some along the time. I am very sorry, but you can I can write the answer. I can answer one and I can write the answer for one. It's up to you.
Okay, so let us just leave the question answer part for you, Dr. Yasser, to answer it in person. Okay, and shall we move, Dr. Saad, to the next presentation straight away?
Please, because the time is very strict, you know. Thank you.
Okay, that's fine. Okay, so thank you very much, Dr. Yasser. Now we're moving to the second lecture, and it's one of my preferred really topics, which is a new fashion now for the ERAS, and we've been last week we're having a very excellent also presentation from Dr. Nabil from the United States about the enhanced recovery in orthopedic anesthesia. Now we are moving into a very talented, innovative speaker, is Professor Medha Chalabi, and he's personally, I'm really honored to be presenting him tonight. He's a founder and president of the Pan-Arab and Middle East Society, and he's vice president of the World Society of Intravenous Anesthesia, the SIVA, if you know about it. And he also a head of anesthesia and preoperative medicine department in Reem Hospital, Abu Dhabi, in United Arab Emirates. So we all know that it's the enhanced recovery is one of these really topics which has become established standards for our daily practice, and actually if you're all aware now, all the Western world, they are more interested in getting the patient as quick as possible out of the hospital. And the anesthetists play a unique and vital role in this success of the all ERAS programs in every specialty. And the strategies and protocol requires a dedicated and organized team for all in the hospital to get this successful patient as quick as possible amputated and discharged from the hospital. So I'm leaving you now with an expert, with Professor Medha Chalabi, and I'm 100% sure that you will enjoy the next lecture. So over to Professor Medha. Thank you.
Thank you very much, Mohammed Mustafa. It's an honor. Thank you very much for the Dr. Saad Mahdi and to everybody. And it's my pleasure and honor to be among this elite group of anesthetists and the perioperative medicine physicians, because this is the right name for our specialty now. And that's why I insisted that my department in the new hospital will be named as Perioperative Medicine Department. And this is the first thing we have to know. Let me first introduce you, or just to give you the definition of enhanced recovery after surgery, because this is very important for all of us to understand. So ERAS, or enhanced recovery after surgery, they are protocols, and they are combinations of evidence-based. So none of what I'm going to tell you today, or what you are going to hear in anything about ERAS, is not a personal opinion. So none of what I'm going to tell you is my personal opinion, but it's to the best available evidence as we speak. And this is very important, because in ERAS, we fight dogmas of many people trying to say, this is the way I do things, this is the other way I do things. And I'm an old man. I started anesthesia, and I started when medicine, when you can go to an exam and they tell you, if you go to Professor X or Professor Y for the same question, you will answer in two different answers, because Professor X believes in one thing and Professor Y believes in another thing. this is not right. It's now to the best evidence. And we should be prepared that in few years, if the evidence changes, we should change our practice to the best available evidence at the time of doing things. And it's perioperative. And this is very important. It's perioperative and suits very well what we say. It's a perioperative medicine, and that's why the name is perioperative medicine. So it's perioperative, preoperative, intraoperative, and post-operative. And Dr. Yasser Zaghloul today mentioned very important things and they make my life easier, because he was saying there are lectures after me about ERAS, and I'm talking about preoperative recovery. This is included. That's why we say it's enhanced recovery after surgery, but it's divided into preoperative, intraoperative, and post-operative. So thank you, Yasser, for that, and thank you for explaining the anemia, which is you will make me able to cut a little bit of what I am going to say. And the post-operative as well, you mentioned about the impact of severe pain on the myocardial function, and it's a sort of stress. So perioperative strategies which work synergistically, and synergistically means 1 + 1 here do not equal 2. 1 + 1 equal 3 and 4 and 5. Because when you do the thing as a package, ERAS is a package, then you will have a much improvement in the outcome than if you employ one of its essential components. And it improves the quality first. And that's why it's very important to remember that, because when ERAS started, it started as fast-track surgery by Professor Henrik Kellet. And when the ERAS Society decided to adopt the fast-track, they changed the name from fast-track surgery into enhanced recovery after surgery, to say that when we are concerned more about the quality, enhanced recovery rather than the speed. And if you do better quality services to your patient, then you will get the speed as a byproduct. So it was very important for me to remind you about all these. This is the definition of ERAS. As anesthetists, we do preoperative, intraoperative, and post-operative. So preoperative assessment is essential. Patient optimization, as Yasser explained to you, for example, about anemia. And then we put the patient to sleep and we do anesthesia for the surgical procedure. And we look after the patient in the immediate post-operative period, not only in the recovery room, but in his room. So in the preoperative, we have the major five, the big five: anemia, control of the glucose level, nutrition, and every one of what I tell you can have its own lecture. So please remember that I'm trying to give you a hint about all the role of the anesthetist in ERAS. So every item of what I am mentioning can be a lecture. There is a lecture. I like my lecture about the role of nutrition in ERAS. It's very essential. Carbohydrate load and the proper hydration, and the blood pressure control, which again Yasser mentioned as part of the intraoperative. So these are very important. Here the blood pressure control is the preoperative one. The preoperative blood pressure. So if you have a hypertensive patient, you control. In other words, you try to optimize your patient, that when your patient comes for surgery, he will be, of course, I'm talking now about elective surgery. I'm talking now elective surgery. So you try to get your patient at the best possible condition for your patient for elective surgery. ERAS now is applicable for emergency surgery, but the preoperative part will be taken away. So we optimize the condition of the patient, such as anemia, diabetes, high blood pressure, cardiac condition, as mentioned, and it was illustrated to you by Yasser. Thank you, Yasser. We rationalize the medications the patient is taking. For example, anticoagulants and antiplatelet medication, we stop them and we do the bridging therapy. You are all aware. So control of medication, and we do that as part of our management for the patient. And then what Yasser didn't mention, because it's a very important part for us, but it's not about medication, is the patient education. This is ERAS, very, very essential in ERAS. Patient education, patient information in the best possible way. And now we are in the we are now in a webinar, so patients now and most of the hospitals are paperless, so we can give them videos, we can give them lots of things, because at the end of the day in ERAS, patients are partners in their care. Remember this, very important. We do everything for the patient, so they are partners. Again, the time where I was a medical student or a junior doctor, when I tell the patient, you're the patient, I'm the doctor, you do as I tell you, has no longer place. Now, the patient is partner in his or her care. We try to avoid sedative pre-medication at the day of surgery, very important in ERAS as well, unless it is really, really, really needed. And then we do something called the carbohydrate load, which you can take a lecture as well. And we allow free clear fluids up to 2 hours pre-operatively. Now, I think in the UK, they are making clear fluids for up to 1 hour only, but here I'm keeping 2 hours, and I'm struggling to keep them 2 hours. We do the carbohydrate load, as I told you, it can be a lecture on its own, but in short, it avoids the dehydration of the patient. The patient feels better. It has metabolic effect, very important, because it reduces the insulin resistance, which can happen due to starvation, prolonged starvation. And there is no increased risk of aspiration. And we ensure the patient is compliant with the volume loading, and not yet in diabetics. So in a healthy patient, not diabetic, you do a carbohydrate load, but not yet in diabetics. Some centers are experimenting to do it with diabetes or not. Antibiotic prophylaxis is very important. We don't do nasogastric tubes anymore. Routine nasogastric tubes are not used. Prophylaxis against post-operative nausea and vomiting, very important. We do use 2 different classes of drugs. Short-acting anesthetic agents, we'll talk about that. And the maintenance, if necessary, and the monitoring. If you are using a non-depolarizing relaxant, you should monitor the neuromuscular block. You should have a monitor for the muscle relaxant. Essential, essential. Depth of anesthesia monitoring is essential in ERAS, and I will tell you why after that. Protective lung ventilation strategy, we use that in ERAS as well. And maintain normoglycemia to the best of our capabilities. And Vena thrombosis prophylaxis, TED stocking, cuff compression devices, chemoprophylaxis for other cases. Of course, for the thromboprophylaxis. And very important is to maintain normothermia for the patient. Very, very important. So you can see these are very important elements, and they are all evidence-based elements which we use intraoperatively in ERAS. When you use analgesia, you use analgesia to minimize the opioid needs post-operatively. Of course, all of you will remember the name opioid-free general anesthesia. There is nothing, and there will be nothing called opioid-free general anesthesia unless you have a typical and excellent nerve block, and the site of the operation allow you to do that. But in major abdominal surgery, I prefer, much prefer the word minimal possible analgesia, or minimal, sorry, not minimal possible analgesia, it's minimal possible opioids. You do everything to minimize the use of opioids. But in some cases, if the patient needs analgesia and you've done everything else, then opioids are a must. Of course, we use goal-directed fluid therapy where appropriate to optimize the cardiac output, to maintain normovolemia, but to avoid fluid excess. We aim for normovolemia, and we try to maintain mean arterial blood pressure above 65 in a normal patient with vasopressors. But when we know that this patient is fluid not sensitive, not fluid responsive. If the patient is fluid responsive, we give volume to achieve the normovolemia. When you have normovolemia, then you give vasopressors. And this means that you monitor intraoperatively the cardiac output by non-invasive monitors of the cardiac output. And I'm sure all of you now know that there are many non-invasive cardiac output monitoring. We maintain optimal hemoglobin for the patient and for the procedure. And I think Yasser has spoken about it and making my life easier now. So for antibiotic prophylaxis, we give single dose, and this dose should be given 15 minutes to 1 hour before skin incision. This is the best time to give antibiotic prophylaxis. We use further doses if the operation is longer than 3 hours or if the blood loss exceeds 1.5 liters. Then we use another dose of the antibiotic prophylaxis. And of course, we have to respect, or the hospital itself, the guideline should respect the antibiotic stewardship. And this is very important. And then sometimes in some centers, 2 further doses appear routine in some centers, not in others. And we do everything else apart from antibiotic prophylaxis to reduce the surgical site infection. For example, by maintaining normothermia, because hypothermia can increase the rate of surgical site infection, for example. Nasogastric, as I told you, can impair return of bowel function, disliked by the patient. It causes sore throat. It increases the incidence of post-operative fever, atelectasis, and pneumonia. Only so the right word, and the British are very clever in writing the right word. So they say routine nasogastric tubes is contraindicated. So it is not routine. So you have to, if you wanted to put a nasogastric tube. So only we insert it if there is gastric distension or requested by the surgeon. And even if it is requested by the surgeon, if you have a surgeon who doesn't believe in ERAS or who is not ERAS follower, you have to discuss. And this is what I was doing. And I know Nader Francis, he's Egyptian, by the way, and he's a surgeon. He's the president of the UK ERAS Society. And I used to call him and I tell him, my surgeon is saying this and this to put a nasogastric tube. Is that right? And he will tell me, yes, he's right, or no, he's not right. And then I can discuss it again. We can, of course, you can put it during the time of surgery, and at the end, you can take it out. And it can protect from aspiration if ileus on the post-operative period. Nausea and vomiting is very important, very, very important. And I can promise all my patients that they will not suffer shivering or hypothermia. Definitely. I tell all my patients about that, and they will not suffer pain, severe pain. Okay, but I cannot promise them that they will not have post-operative nausea and vomiting. I always tell my patients in the preoperative, as part of the patient engagement and patient knowledge, is that I will do my best to minimize the incidence of post-operative nausea and vomiting. And thank God, the results of the centers I work in are usually below the incidence of post-operative nausea and vomiting is below the international benchmarks. It means we are doing good work. But I cannot promise my patient 100% that they will not have nausea and vomiting. We do our best. We give prophylactic antiemetics, usually two, and all of you are aware of that. We use, I use granisetron, for example, and I use dexamethasone. I avoid the use of nitrous oxide. And of course, we use minimal possible opioids, as I explained to you. In patients with very high risk of postoperative nausea and vomiting, I consider seriously using propofol by TCI. It's usually TCI, propofol, and remifentanil as the way of anesthesia because they reduce the postoperative nausea and vomiting. When we use anesthetic agents, we go for the shortest acting agents. So for induction, I use propofol, opioids depending on the type of the operation, or no opioid if I have a nerve block, ultrasound guided nerve block, which can help, and then we can definitely avoid any opioids. Short acting muscle relaxants when you use them. Sometimes in bariatric surgery, and this can be a lecture on its own, I use Presidex as pre-anesthetic medication as part of the multimodal analgesic technique to reduce the opioid, or going for opioid, near opioid free, minimal possible opioid. For maintenance, I don't use nitrous oxide, and I'm sure people from the UK, they now very rarely use nitrous oxide. We use air and oxygen mixture, and I use only desflurane. Yes, so you can achieve everything with SIVO, but desflurane is the best if you use it properly. And I think if you, as I told you, in ERAS, it's synergism. You get 1 + 1 do not equal 2, they equal 3 and 4 or 5. And I will show you that at the end of my surgery, my patients are fully awake, which you can achieve with SIVO still, but use the best you can use. And the desflurane, in not my opinion, because there is no opinion, but it's according to the blood gas solubility and according to the data of the drugs, it is the best. Remifentanil infusion for short-acting opioids, you use that. Of course, in general case or abdominal case. If you are using a neuromuscular blocker, ensure adequate muscle relaxation, facilitate surgery, of course, such as bariatric surgery, and the let the surgeon operate at a lower abdominal pressure, but at the end, ensure full reversal of the neuromuscular blocker. And this is very important, and monitoring is essential in that. Then when you use inhalational, if you are using inhalational, you should use anesthetic agent monitor and depth of anesthesia monitor. And the depth of anesthesia monitor, when it started first, they were starting it to avoid awareness. And actually, the only advantage of using inhalational drug is to avoid awareness. But now, what can you do to make sure that this patient is not taking too much anesthetic? If you are relying on the hemodynamics, you're very crude, and the MAC value is very crude. And I use, in any long operation, I use depth of anesthesia monitor. And by this, I found out that in many of our cases, I use much lower. I'm not achieving 1 MAC, or sometimes, or I go for half MAC, and I'm achieving the level of anesthesia I want. So this is very important, especially in the elderly, because it reduces the post-operative cognitive dysfunction, and this is very important. And there is something as well, which if you use the depth of anesthesia monitoring, there is PQRS, post-operative quality of recovery score, which is very important, and it shows if you are using desflurane and if you are using depth of anesthesia monitoring, or if you are using total intravenous by TCI, Dvt TCI, then the postoperative cognitive dysfunction is much less, and the recovery, the quality, the PQRS is much better. Perioperative glucose control, poor glycemic control increase the risk of complications, of course. So we need tight glycemic, if we use tight glycemic control, we increase the risk of hypoglycemic event. So we try to maintain normal glucose level. Remember that this is in glucose. You will find the same in fluid management. Not too tight, not too strict, and not too liberal. So normal, near normal is the best. خير الأمور الوسط. Short-term insulin glucose level necessary if the patient becomes insulin resistant. And if the patient becomes insulin resistant only because of anesthesia, it's the anesthetist's fault. Because in your anesthesia, in your ERAS anesthesia, which should be the appropriate technique for all our patients, you should try to make it as much less stress response as possible. Body temperature, very important. And I can tell you, there are two reasons by which I introduced the ERAS to the whole Middle East. These two reasons, that when I came back from the UK and I came to practice in the Middle East, I found my patients, or some patients, not my own patients, but sometimes I found in recovery in many hospitals, patients are suffering from pain or shivering and hypothermia. In the proper anesthesia, and I insist on that, we do not treat hypothermia. We do not treat shivering. We prevent hypothermia, we prevent shivering. And this should be a key point indicator of any perioperative medicine department, anesthesia department, that hypothermia is preventable. And I don't think it's acceptable now to have any of our patients post-operatively with shivering. We use every possible way, warm air blowers, underbody heating, warm IV fluids, and it starts again. It's like exactly like ERAS. It starts from the preoperative. By patient education, we tell the patient that when they are in the room and the air condition is too cold, they have to inform the nurses to raise the temperature. So patient can walk to the anesthesia, to the theater. If not, there is contraindication for the patient to walk to the theater, but it's much better to walk to generate heat. And then we maintain normothermia and we look after it. I can dedicate another lecture completely for the prevention of unintentional hypothermia, because hypothermia increases the risk of wound infection, increase bleeding and transfusion requirements, shivering increase oxygen consumption, and it's a very distressful thing for the patient, and it worsens the pain scores. And if you prevent hypothermia, there is reduction of morbid myocardial events. So, and hypothermia can kill, simply. Hypothermia can kill. For the ventilation, of course, protective lung ventilation, I'm sure you are all much better than me in doing that. We use small tidal volume, 6 to 8 mils per kilogram, protects against lung damage, optimal PEEP, reduces microaspiration. But when you are using non-invasive cardiac output monitoring and you're using 6 mils per kilogram of the, for part of the protective lung ventilation, the readings are not very good. So I go for 8 mils in ventilated patient to allow the use of stroke volume variation and pulse pressure variability. Vena thromboembolism, we do scoring of the risk. We use TED stockings when possible, cuff compressions. Early mobilization in ERAS is very important. And of course, if the patient fulfills the criteria for early embolization, for prophylaxis, we use that, and extended prophylaxis, and fluid therapy can help a lot. Patients with cancer and chemotherapy and on chemotherapy, they are more likely to develop these, so we have to do extra efforts. Analgesia. Analgesia simply opioid sparing. We minimize the use of opioid. We want effective analgesia because it's humanitarian, it's human for the patient not to suffer any pain. It allows mobilization, and we should avoid and do opioid sparing things. The oral multimodal, we use paracetamol plus non-steroidal unless contraindicated. So I use both of them routinely unless contraindicated by any reason. Oral, as I said, paracetamol and non-steroidal. Analgesia should be effective and allow mobilization and opioid sparing. We use central neuroaxial, we use truncal, such as tab blocks, rectus sheath catheters, and blocks and wound infusion catheter, any way to prevent pain and to minimize opioids. Of course, there are now experts, and most of you are experts in the ultrasound guided nerve blocks, and this can lead, the only thing which I believe can lead to opioid-free anesthesia. So when you are dealing with analgesia for your patient, you wanted to optimize the patient comfort, you want the fast functional recovery of the patient, and you want few side effects. And when you do that, you encourage what we encourage post-operative dreams. And dreams means early drinking, early eating, early mobilization, and the proper sleeping for the patient. So this is our aim by good analgesia for our patient in the post-operative period. And of course, analgesia can take lectures and lectures for the role of analgesia and how can we give multimodal and opioid-free and minimal possible opioids. We come to the fluid, the same again. At certain time, they were giving liberal amount of fluid, which lead to hypervolemia and bowel edema. At other times, they were using restrictive fluid. So here is the restrictive fluid, which can lead to bowel ischemia. And when they give too much fluid, it leads to bowel edema. So overload is not good, underload is not good. We are working to reach this optimal spot. This is the best way, is to give the right amount of fluid. So restrictive is not good, liberal is not good. The optimal fluid therapy is to give the right amount of the right fluid at the right time. Remember this. And again, this can be a whole lecture, and many lectures when we do that. So ERAS fluid therapy, we avoid fluid shifts. That's why we avoid bowel preparation. We give carbohydrate load, and we allow fluids up to 2 hours preoperatively. And then the patient will come to you in a state not dehydrated. And then intraoperative, we use individualized goal-directed fluid therapy to maintain normovolemia, to optimize the oxygen delivery to tissue. And when the patient is normovolemic, then you use vasopressors to maintain the mean arterial blood pressure to avoid hypotension. We optimize the hemoglobin, very important, and individualized, of course, because it depends on the patient and his condition, and Yasser spoken very nicely about this. We maintain normovolemia, we restrict salt and intravenous fluid, and we start early feeding. All my patients, or most of my patients, more than 90% of my patients will start drinking tea, coffee, juice, or water in the recovery room, even after bariatric surgery. The following significantly affect fluid shifts and requirements. Open surgery and prolonged surgery will delay that. Blood loss, of course, and prolonged systemic inflammatory response or sepsis, they will delay and they cause fluid shifts, and they are very detrimental to us. The vital organ optimization during surgery, and Yasser has mentioned that very nicely as well. We optimize the cardiac output, we optimize the oxygen and the nutrients delivery. Try to ensure normovolemia. See how many times I talked about that, and the monitoring, the non-invasive cardiac output monitor. I predict, and remember that I'm predicting from now that in the future we will use non-invasive cardiac output monitors exactly as we are using blood pressure monitors now, because of course predicting and knowing exactly the volume status and the cardiac output, the flow is more important than knowing the pressure, because the pressure is a product of resistance to flow. We maintain the mean arterial blood pressure when the patient is normovolemic by vasopressor, and we optimize the hemoglobin. This is to give the minimal amount of intravenous fluid to achieve the above. Mean arterial pressure, does it matter? Of course. Yasser showed in his excellent lecture that it matters. It really, really matters. So for the mean arterial pressure, if it is reduced below 65, there is an increased risk of kidney injury, delirium, myocardial injury, as Yasser mentioned, infection. The effects of these delirious effects increase by the duration and the magnitude below 65. Then an individualized mean arterial blood pressure target, it should be individualized because this patient might be a hypertensive patient, so there is a shift of the response and to the oxygen delivery, etc. So, and the individualized mean arterial blood pressure target may be beneficial, but flow, as I told you, the cardiac output must be optimized first. So, in enhanced recovery, we give effective analgesia, individualized fluid therapy, and then in the post-operatively, early mobility of the patient is essential by effective analgesia as well. It will lead to early mobility. Enhanced recovery will have early gut function, very important, because we allow them to drink. We don't wait and we don't listen to peristalsis anymore. On the contrary, when you give chewing gum for the patient, they tend to do better. And when you let them drink in the recovery room, it's much better. And we try to modulate the stress response and minimize the stress response. Early gut function will lead to better healing. Early mobility will lead to decreased length of hospital stay. And the modulation of stress response will decrease the complications. I'm showing here a video for you for one of my patients, which we've done. It was not in my hospital. It was actually a workshop in the 3rd IRAS conference of the Middle East in Oman. And this patient received a long operation, about 4 hours. It was the 3rd redo for bariatric surgery. And you can see this patient in the recovery room in about 10 minutes. Oops, sorry, I wanted to go again. Yeah, I wanted to show the video. Sulaiman, we just finished the bypass operation. It's a redo. And he's now 10 minutes or 15 minutes in the recovery room. Sulaiman, how are you feeling? أخبارك إيه?
Good, alhamdulillah.
Alhamdulillah. Now we asked him to sit on the edge of So he will sit on the edge of the bed for 10 minutes, and then to make sure he's not drowsy, etc. And now I asked it. The nurses were amazed because they are not my normal nurses, and it was like for the first time they have seen this experience. And the patient to mobilize, assist him, assist him, assist. Okay. Look down, yeah, and start to move. Start to move. Excellent. Excellent. Yes. Stand up, take a nice deep breath, and start to move. Don't close your eyes, don't look down. So he walked, and he's coming back. So, ladies and gentlemen, it was an honor talking to you. Thank you very much for being such a great audience. And I hope all your patients will get benefit from using the ERAS protocols. And there are so many things in ERAS which need to be discussed and talked about. As I told you, every item I mentioned can have its own lecture or lectures, actually. It's an honor to be with you. Thank you very much for being such a great audience. Thank you.
Thank you, Dr. Medha. It's really, really fantastic. Honestly, I really personally enjoyed it. To the point, really summarize and to the point. It's absolutely really one of the best lectures I've seen about the enhanced recovery. And thank you very much.
Yeah. Thank you.
I encourage all the attendance. Really, it's very important, guys, just to keep in touch with our experts. It's really Dr. Saad makes a great effort to keep them with us today. And it's if such a someone like an expert like Dr. Medha, you will struggle if you get in touch with him. So keep on interacting and send questions, and this is the main aim. These lectures will be available in YouTube and available on our platform. However, extremely important to catch the chance of being in touch and getting interacted with the experts. So of course, Professor Medha, it's really a hot topic, and as you mentioned, I amazed with your patient in the recovery. I had a similar patient with a major colorectal, and we used to have such also in a previous era when we have to do an abdominoperineal surgeries, and the patients, go to the ITU with a lot of tube and a lot of in and out, and patients getting sometimes intubated, and I started to believe personally in this in this fantastic way of managing patients from a multidisciplinary pattern. It's not only about the anesthetic; it's also about the surgery, about the teamwork. And I remember as such the same patient like you had at the end of your lecture, and I amazed that at the end actually we've done a major colorectal, and when I was going home at the end of my list, I've seen him actually sitting in Costa, so he was drinking coffee in Costa.
Exactly.
Yeah, so this is absolutely, guys, it's really, it's nothing about only literature, it's also about from clinical aspect, like mentioned by Dr. Medha. It's now an era of how we can move away from keeping patient hospital. Now, as you've expecting, Dr. Medha, you have lots of questions, and I will just select some of and I will keep the others for you just to keep going with our program today. So Dr. Ahmed Khattab, he's mentioned that is in ERAS protocol, why not periodizing TIVA versus inhalation-based anesthesia? I think you mentioned this.
Why again? What does?
Why not periodizing TIVA versus inhalational-based?
Of course, we use TIVA a lot. I am the vice president of the World Society of Intravenous Anesthesia, but I always wanted to say, I use TIVA a lot, but still, if you're using desflurane in the right way, you can achieve, and it's not about one thing. It's not about inhalational or it's about everything together, the package, the package.
Yes.
Any of these patients, if the patient was cold, he will never awake like this. If the patient was in pain, he will never wake like this. So it's a whole thing together.
Yeah, absolutely, agree 100%. So, Dr. Ahmed Khattab, as you heard from Dr. Medhat, it's a multimodal. It's something which is not about only one limb. It's just all about the whole thing together. It's like a package. So if you provide your patients with a multiple versatile ways of enhancing his recovery and keep him out of the bed, it does work. It's not only about one agent versus the other. Right, Professor Medhat, also you have a question here from Dr. Ahmed Khattab. What's the best carbohydrate load? So I think
depends where he is in which country, because it's not available everywhere. It's available in Dubai. I found a company which can provide me with a carbohydrate load. In the UK, there are many choices. In America, there is a company which became the best company just because they have a very good carbohydrate load. You can see it's a good business as well. So it depends. If you don't have in your hospital or in your country, I don't know where he practiced, if you don't have anything, then the least you can do, which is not like a good thing, a very good thing, but the least you can do is to ask them to drink clear apple juice. But it doesn't fulfill but at least if the patient can drink or like to drink apple juice, I prefer it to water. So he can drink a lot of apple juice pre-operatively.
I think there's out of the commercial thing, there's a lot of the energy drinks with sports they use.
Exactly, but avoid energy drinks. In Europe again, there are energy drinks which can be, and this American company actually produces one, and then the sportsmen started to use it.
Okay.
So yeah,
that's fine. Right, Dr. Medhat. From Mohammed Suleiman, is dexmedetomidine can delay recovery.
Sorry, again?
So can delay recovery. So how to use it properly? I don't think that's good.
Exactly. There is another lecture I can promise you guys to give you a lecture about ERAS in bariatric surgery. And this is the lecture which I show exactly how I use Presidex, because in ERAS, we don't like to give pre-medication. Okay? We don't use midazolam. I don't use midazolam at all. So then, patient coming for major surgery, major abdominal surgery, when they come to my holding area, I put an intravenous and I start Presidex. As a pre-medication, because again, in the UK, we used to have anesthesia room where you induce and the patient goes to the room. But here in the Gulf, the patient goes to a huge room and the nurses are scrubbing and preparing. It's really very hostile to the patient to go, for example, going for oncology surgery, a man or a woman coming for a major oncology surgery, and they go into a room, sometimes cold. In my case, I never make the room cold. I make sure the room temperature is above 23 when the patient goes inside the room. And I urge all of you to do the same till the patient is covered and induced. And then I use in the holding area Presidex. So the patient will have good pre-medication preoperatively, and I give the antibiotic, etc., and then I wheel the patient into the room. So he will be calmer. And this is part of the multimodal analgesia to minimize the use of opioids. And then the patient recovery will be like this. So this patient, which you have seen, has had Presidex. It's one of the patients because he's a bariatric patient.
Just as a personal question, Dr. Medha, do you find a difference in your clinical, because between the remifentanil and the Presidex for enhanced recovery, do you have any specific preference?
But I wouldn't compare them, because the role of Presidex, as I explained to you, I use it preoperative, and then I reduce the rate intraoperative, and I don't use remifentanil here. Okay?
Yeah.
Remifentanil, I use it mainly, and it should be TCI again.
Yeah.
TCI remifentanil and the TCI propofol as Tiva TCI.
Yeah.
Then you have a Tiva TCI patient and a wonderful recovery.
Yeah.
So it is not, I am comparing this against this. I am using this to the best of its abilities, and I'm using that for the best of its abilities.
Yeah. That's fine. Dr. Medha, thank you very much. Really, personally, I've enjoyed. I enjoyed to the most, and I wish we have you all every week with us here.
It's my pleasure, actually, and I think I'm an old man now. I'm in a time where I would love that all the new generations to see and to learn from us, to learn from our mistakes, yeah, as well as to learn from the good things we say. But it's my pleasure and my honor, and I think it's a mission we should all do.
Absolutely. Thank you very much, Professor Medha, and have a lovely night. Thank you.
Thank you.
Right. We're moving now to a much related, really, presentation, which is again in the same territory of the ERAS, and is now for Dr. Haytham Jamil, and he's Dr. Haytham is a cardiothoracic anesthetist in consultant in Aberdeen, United Kingdom, and he also is going to teach us now and give us some.
Can I just ask one question?
Absolutely.
Is Nigel Webster still in Aberdeen?
No. No, left a long time ago, I think.
Okay, that was my question. He's a very good friend of mine.
I heard about him, actually, and he seems a very, very, very nice guy, and everybody just keep on talking about him. Yeah.
He used to love Egypt, actually. He came many times to Egypt, yes.
Exactly, yeah. Pleasure, really.
That's fine. So Dr. Haytham, he's going to enrich us again with about now about Dr. Haytham about the ERAS in cardiac surgery. It's one of the topics which is we have now a lot of ERASs coming on different areas, and I think also in our hospital we have the ERAS in obstetrics. There is an ERAS in of course for the orthopedic, colorectal, a lot of now they also going into a lot of other subspecialties, and this is one of the things which is I was expecting to hear from you, Dr. Haytham, today, and is about one of the areas which is in most which is away from it, just a cardiac ERAS and cardiac surgery. So I'm 100% sure that you're going to give us a very fantastic lecture, and we'll get taught nicely tonight. Thank you very much, Dr. Haytham. Over to you.
Oh, thank you very much, Dr. Muhammad. Actually, as you mentioned, it's an ERA, not an ERAS. So probably it became really started in many surgeries, and then currently we get a consensus actually to apply it in the cardiac surgery. However, let me start first with say that I'm very delighted actually to join this group of eminent speakers under the very role moderation of Dr. Muhammad Mustafa. Dr. Muhammad, really, I enjoyed many of your lectures. Our participation in the communication skill course was really amazing, and was a very good really addition to my career as well. So thank you for everyone, ladies and gentlemen. And I will start really with the ERAS, and I think definitely Dr. Professor Medha Chalabi actually make the things like much more easier for me as well, because he put the fundamentals, the basics of the ERAS that came up with the kind of evolution to be applied as an era in the field of the cardiac surgery. Well, I will not go definitely with the definitions, because I think Dr. Medhat actually managed to speak about it really in a very, very nice, detailed way. But it's a protocol-based multidisciplinary design to improve the various outcomes. And definitely it covers the preoperative and the intraoperative and post-operative periods by forming a kind of a bundles that it will be applied on those kind of periods in order to achieve the preferable outcome at the end. However, recently it became one of the forefront in the cardiac surgery. It started actually with Fleming et al. When you think that is it possible, I mean, is it applicable to apply the ERAS as a form of a protocol that could be applied in the cardiac surgery for CABG and valve in particular. The protocol include the ERAS-based strategies, such as reducing the preoperative fasting, minimizing the long-acting opioids, as simple as that, and applying the early start of the enteral feeding for those patients who stays for more than 24 hours or maybe 48 hours in the ITU, and facilitates and encourages the early immobilization as well. However, there is no significant difference in the length of the stay, and that's what makes him really have some sort of being skeptical slightly about getting a benefit from applying it in the cardiac surgery. However, there is some significant statistical difference in the decrease in some of the complications, including the infection and renal injury, or maybe MI, or maybe at the end the morbidity and the mortality or the development of death rate. You can see here that the ERAS here actually is having three main bundles. One definitely for the preoperative, covers the intraoperative and the post-operative. But I think you agree with me that the cardiac surgery actually going in a different way, heading away from the simple protocol, because it's a complex surgery. It is a costly surgery that actually consuming huge resources, and most of those patients actually having plenty of the comorbidities that might really affect the outcome at the end. And definitely those patients have a different post-operative course. They will not really tend to goes directly on the day surgery basis. We know that most of them should go to the HDU or the ITU. I will not go definitely through the components of those bundles, because I think Dr. Medhat actually managed to speak in details about it. However, now before the 2019, when the ERAS Cardiac Society released the first consensus that reviewed and came out with a very good guidelines for the patients undergoing the cardiac surgery, and they refer it to be the enhanced recovery after the cardiac surgery. There are many challenges to implement this in the field of the cardiac surgery. However, the cardiac surgery care has always involved definitely the cooperation and the collaboration between the multidisciplinary team, that it might really helps at the end to reach this consensus and to facilitate the post-surgical recovery as well. The aims in the cardiac surgery, and all of us know very well that it's a costly and it's time-consuming, it's effort-consuming as well, is to decrease the hospital length of the stay as much as we can, decrease the complications, the readmission rates and costs. Maybe we can apply it in a simple way, just to get guidelines, just to reach a consensus that really know how to deal in a proper way with those patients who came with a comorbidities, complex surgeries, and finally getting a significant reduction in the resources. I tried to hide the name of the companies, but actually we can check here actually that it's a kind of a post, but sometimes it's a ghost. Why it's good? It's similar like the ghost, because actually it's hard to figure out the exact cost of the hospital stay, and it differs from let me say, from an insurance company to different agents to different health providers. So at the end, it varies from 9,800 up to 11,700 in general per pay. However, if you can get really a very clear way to measure it, you can't really be able to manage it effectively. This actually is as simple as that it might really varies between the $29 per minute for the low complexity surgery up to $80 per minute for the high complexity cases inside the theater or in the back, or even during the taking the patient from the theater back to the ITU or the ICU. The average cost actually per day varies from one country to another. In the United States, up to $5,200 almost, and the cheapest is in Spain with a $424, which is quite cheap actually. So when building the ERAS protocol has been referred by Nausea, the complication and the length of stay actually affects really significantly the cost of the stay. Definitely, we should consider that those patients goes directly to the ITU. It requires a huge resources, a huge efforts that actually varies between a patient to another, and definitely the cost actually getting much more significantly higher with the age group between 45 years old to 84, and this is very well explained because of actually the old age means that they have plenty of comorbidities. Those are the bundles actually for the application or for the maintenance of the ERAS in the cardiac surgery. I start with the preoperative consideration, which actually vary from the preoperative components, the intraoperative components, and the post-operative, and it slightly might really be able to be merged easily with the ERAS in the non-cardiac surgery. However, there is a few modifications, let me say, the few changes, few components that might be added, and I'm gonna talk about it, especially with the preoperative. And as Professor Medha mentioned, actually it starts really so early, rather than keeping the patient really in the fast track to be recovered. It starts even from the preoperative period. I would say that three main components in the cardiac surgery. We should maintain what we call the stop, optimize, and encourage. Stop what? Stop the alcohol, smoking, drugs with the possibility just to apply this component quite earlier, up to 1 month, for instance. Optimize the blood sugar and the fasting period, and encourage for good nutrition and education and for patient and the patient involvement. Here, the infection and respiratory issues, especially, it might really cause a slower wound healing and might really precipitate a kind of bleeding and metabolic dysfunction. And that's why those, let me say, hazardous beverage should be actually stopped a little bit early, up to 1 month before the surgery, in order to avoid those complications. Again, the hyperglycemia is a very common in the cardiac surgical patient. Most of them actually have a peripheral vascular disease because of, on top of the blood sugar problems, they are receiving insulin. However, how far we can just manage to apply this control, it differs from one protocol to another. However, we should maintain that the hemoglobin A1C should be really maintained in a very reasonable level before the surgery. We should really take into our consideration as well as that the 25% of our cardiac patients actually have a higher HbA1c, and almost like 10% of them actually is actually undiagnosed with this diabetes, or be diagnosed really by accident whenever they being tested for the surgery. Maintaining the level the blood sugar normoglycemic level and avoiding the tight control definitely is really preferable in those patients. And this is actually goes in line with and very adherent to the normal ERAS protocol. Most efficiently here, we should use the insulin infusion. And whenever it's possible, probably you should keep the HbA1c just below 6.5% and avoid the tight glucose control, because definitely it might really cause hypoglycemia, which is definitely should be treated immediately if being discovered. How we can optimize the fasting period for those patients? So again, we know from the beginning that it might really stay fasting for 2 or 4 hours at least above before the GA, before the starting the conduction of general anesthetics, should be really taken slightly cautiously, because some of them, as we mentioned, is diabetic. So probably the 2 to 4 hours, I think, if we can minimize even up to 2 hours, probably giving them a clear fluid definitely could be very, very tidy for them actually in terms of the satisfaction, their satisfaction. And there is no, by the way, there's no risk of having an aspiration during the procedure. The clear liquid loading could be given up to 2 hours before the surgery, and definitely this will help to reduce the insulin resistance. And what we need just to emphasize here that the insulin resistance definitely affects the inotropic support, affects also the period of staying on the bypass, and might have a different consequences in the post-operative period as well. Encouraging the patient engagement, making sure that you have a very good functional capacity, it should be emphasized, and moreover, improving the patient engagement through his education, through very, very well significant, really explanation for the whole process, definitely would really have a very good consequence in the post-operative period. Here, the nutrition should be maintained in a different way. Actually, the guidelines supports really to maximize the nutritional status in the preoperative period. And definitely this bundle should be started a little bit earlier, 7 up to 10 days from the procedure. Definitely encouraging the patient as well to perform any kind of preoperative exercises associated definitely with the less preoperative insulin resistance, and definitely will affect even the hemodynamic stability as well, and make the condition much more neat and tidy. Okay. I'm trying to go to the next slide. Oh, sorry.
Go to the last and come back to the next.
Okay. No, I'm stuck here, unfortunately. Okay, so. Okay, now, yeah. So going to the intraoperative consideration now, and the intraoperative consideration is slightly different, because here, compared to the ERAS, the normal ERAS protocol, or the cardiac ERAS protocol, we have the bypass. The patient who goes on bypass, the patient will have a huge wound in his sternum. Plenty of people actually provoking marvelous efforts in order to keep this patient safe at the end. Here, the most important surgical wound site of infection will be the sternal wound, definitely. And this should be actually taken in consideration whenever we try to control this infection. And about 1 to 4% of the cardiac surgeries might really have a kind of morbidity or mortality because of this wound actor. The main organism here is Staph aureus in most probably 30% of the cardiac patients. And that's why, according to their guidelines, we should encourage the intranasal Staph aureus therapy, and the different protocols based on the facility or based on the local protocols to apply the intraoperative antibiotics in order to avoid those infections. Here, we should maintain at an anesthetist the use of the short-acting medication. For instance, using the remifentanil TCI. Remifentanil is a very good drug, short-acting drug. It could be actually continued even in the post-operative period as well. The depth of anesthesia should be monitored with the use of BES or with entropy. And moreover, the relying more on the short-acting drug like the dexmedetomidine now is being encouraged, but definitely not in the theater, mainly in the post-operative period in the ITU. Here, to consider the monitoring, which is really very, very important component of the maintenance of the adequate hemodynamic stability, we should encourage the use of goal-directed fluid therapy using the pulse contour analysis monitor, whatever it is, and there is no conflict of interest here. You have plenty of options, plenty of brands actually that might really helps you to retrieve a kind of a data about the cardiac index, about the MVO2 saturation, the urine, for instance, getting informations about the SVV, stroke volume variation or stroke volume index, getting informations about the SVR, the resistance or the pulmonary vascular resistance, the extravascular lung water. The main thing here actually is to tailor the use of your inotropes, your vasopressors, your volume, in order just to give the right thing to retrieve the adequate hemodynamic stability. The application of new parameters like the hypotension predictive index, it might really helps along with the use of the SVV and the other parameters like the BBV and the other parameters in order just to choose the right thing in order to maintain the hemodynamic stability with the least manipulation, with the using the inotropes or the vasopressors and maintaining the eovolemia and at the same time adequate hemodynamic stability. And definitely this will help actually to initiate the early weaning of the inotropes and maintaining the hemodynamic stability. During the bypass, encourage your colleagues in the perfusion department or in your perfusion team to encourage the adequate cerebral protection, initiating or applying the cerebral protective strategies, maintaining cardiovascular protective strategies for aortic or for valvular or for the coronary surgeries, maintaining the renal protection. Try to limit the cross-clamp time. The bypass, probably we need definitely a very fast and very well expert in this field actually. And moreover, adequate blood transfusion if the hemoglobin is above 10 or 11, and that currently has been applied in many centers as well in many protocols. In case of if you are really concerned about the renal perfusion, probably the higher cardiopulmonary bypass flow might really imposed or maybe implemented in order just to maintain adequate renal perfusion. And we'll see this later just because it might really helps to prevent and to avoid the AKI. Here, the guidelines for the pain management actually is important and is slightly very close and very adherent also to the ERAS protocol in the non-cardiac surgery. Here, we encourage and they recommend as well the use of multimodal opioid sparing approach. How just try to use the opioid if you can just apply the short-acting opioid if you need just to use the opioid as definitely as a considerable way to control the pain. Try to use adjuvants to lower the opioid requirements using the acetaminophen, gabapentin, which becomes more popular now, tramadol, which is very popular as well, using the dexmedetomidine, using the ketamine, lidocaine, magnesium, and some of the steroids as well for controlling the PONV or the nausea and vomiting as well, along with the use of those medications. Definitely compared to the the normal ERAS, or let me say the usual ERAS in the non-cardiac surgery, we should avoid the use of non-SAIDs because have definitely a very bad consequences in terms of thromboembolic risks, and it should be avoided definitely in the cardiac surgery. Here actually it's really a little bit controversial because I think it will be difficult actually to get a consensus with the surgeon that we can use the nerve blocks targeting the intercostal nerves that it actually fits the lateral and anterior chest walls. Currently becomes a little bit popular to apply the pectoralis nerve block or serratus anterior, or maybe erectrospiny single shot. Definitely avoid the catheters. There's no place to catheters. There's no room for the catheters here actually, because those patients, as we all know, receiving heparin for going on bypass and definitely reversal. However, avoiding if you're willing actually to give nerve blocks, you should avoid the transversus thoracic muscle brain block, because it might really damage the lima and rema, and the left internal memory and the right internal memory, and might lead actually to spillage of the local anesthetics to the mediastinal cavity. However, we still actually it's not widely applied in most of the centers now, because I think it might really find a kind of a resistance from the surgical team, because and this, if the patient develop any kind of hematoma, definitely they might really blame the nerve block for that. The maintaining the normothermia is one of the main targets here, and avoiding also the hyperthermia, or definitely we should actually the hyperthermia is not really deliberately occurs, but in case of you need to rewarm the patient, don't over rewarm him because it might really affects the cognitive dysfunction, might have a very big consequences on the infection and the healing as well. And definitely avoid the hypothermia, because it might really cause problems with the bleeding, might really precipitate infection, and definitely it might really increase the mortality and actually elongate the hospital stay as well. Here, we reach the guidelines from the Society of the Cardiovascular Anesthetists and about the use of the thromboelastography, TEG or ROTEM, in order to achieve actually the best management for the blood and blood product, and just tailor out your choices in order just to give FFP or platelet in case of the patient still really having problem with the bleeding or like dumping a lot of blood in the chest tube. Here, to avoid that as well, the guidelines really emphasize and recommend on using the IACA or as antifibrinolytic medications. The IACA means the epsilon aminocaproic acid, or the tranexamic, which is actually much more famous. And definitely this might really helps to reduce the blood products and limits the need of transfusion and over transfusion as well. I will reach the post-operative consideration, which is actually to be kept on our loop, because to keep you away from the obstacles that might really prevent you from the reach or to achieve the adequate recovery for your patient. It starts really mainly in the post-operative period. For instance, the prolonged ventilation. So you should have a protective lung strategy, hemodynamic stability, and you should really apply monitors. AKI should be considered. The bleeding and the possibility of having a blood replacement plan should be taken into consideration as well. If the patient having a delirium, BOCD definitely will stay for ages in your ITU, and finally the Dvt protection as well. Let me start first with the protective lung strategy, and as simple as been mentioned, you can just apply whatever you think that is safe for your patients. However, try to minimize the mechanical ventilation, initiates the protocol that helps actually to encourage the early extubation up to 6 hours after the ICU admission. It could be as safe if the patient definitely have a very good blood gases, and we should consider that the patient safety is first. So it's not really running. We are not really running after the ERAS, or ERAS in the cardiac surgery, and at the same time neglecting or ignoring the patient's safety. However, if the patient is fine, they have a very good ABG, and you apply the protective lung strategy from the beginning, you can actually go for the extubation, and this definitely will limit his stay and definitely will have a very good consequences on his recovery. AKI, the acute kidney injury is very common and definitely is very costly in terms of this long length of the stay in the hospital as well, or in the HDU or in the ITU in general. We have currently they came with a kind of a urinary biomarkers that might really helps to predict and facilitate the risk stratification and definitely the early intervention of the AKI. My advice actually to involve the nephrology team. They might have, rather than giving like furosemide and or Lasix or giving spironolactone for the patient with heart failure, probably the involvement of the nephrology team definitely will actually make a very, very significant difference, because you might really need to start the filter or the CRRT as early as possible. Definitely during the bypass time as well, you might really encourage your crew and the perfusion team to start the ultrafiltration, or encouraging them in some particular situations to apply a higher bypass flow to provide a renal perfusion strategy. Here, the delirium is very common, especially with the elderly patients, and most of the elderly patients have a cardiac problem, and most of them are really wheeled directly to the cardiac surgery. However, it's up to 50% in some of the studies. And apart from that, it might really had a very significant really impact on the cognitive recovery of our patients, and might really precipitate very bad consequences as well in terms of staying in the hospital. Definitely, we should consider that the long-acting medication, whether it's sedatives, opioids, and anxiolytics, might really definitely have a very bad impact in the development of this delirium and the cognitive dysfunction. Therefore, you should consider that the delirium should be monitored very regularly, and to be attacked and be counteracted, to have a very good approach in order to control it as early as possible. One of the main bundles actually should be applied with those patients is the non-pharmacological treatment. Try to avoid the pharmacological treatment or the chemical treatment as much as you can. Like simply, you can change the sceneries, encourage the family visits, and the involvement of the patients with a very nice and very friendly talk. Educate the family about the possibility of development of this and then the behavioral changes and other things. Put him in a quiet room with a low lighting. Let him have a very good sleep, because the main problem with most of our ITU and most of our really, let me say, our healthcare providers, or let me say our nurses, they are doing their best actually to help the patient. They are doing the washing for the patient, doing grooming, doing the patient care, and that might really having a problem about the disturbance, with the disturbance of the sleep rhythm, and it ends after 2 or maybe 4 days to develop this kind of delirium or a confusion. And encourage, by the way, don't, if you can, don't ignore that the patient might have a problem in his ears. So give him the hearing aids or his glasses so he can see and really listen clearly. Here, you should maintain a very close observation for the preoperative anemia. Avoid the anemia. Preoperative nausea and vomiting should be really treated, and you should have a prophylaxis to avoid it as early as possible as well. The early post-operative enteral feeding might really advised and many emphasized in many protocols as well. The early physical rehabilitation is required. Try to, if it's safe, try to remove the chest drain if it is within the protocol as soon as possible. Try to sit the patient, mobilize him to the chair as soon as possible, if it's safe, definitely, with the aid of our really gorgeous physiotherapists. The aim mainly is to avoid the development of the Dvt and the pulmonary embolism, which should be preventable actually in the cardiac surgery, and relying on the mechanical thromboprophylaxis using the below-knee socks or the pumps, or sitting on the chair. Definitely much more advisable and much more really profitable in terms of compared and might really outweigh the use of the chemical thromboprophylaxis. However, if you need it, you can start it from the day one of the surgery, especially with the valvular heart surgery as well. Here, the chest tube, we should involve really the cardiac surgical assistants or the cardiac surgical team as well, to avoid the clogging, which is really fairly common with the cardiac surgery and may lead to the pericardial effusion, definitely a critical hemothoraxes. It might really end with AF and hemodynamic stability and start really to run for further re-exploration in the wounds as well. The unclogging, usual milking, it might really provided using the smaller tube, and the suction definitely is one of the main maneuvers to avoid it. And if you can apply the new chest tubes, it might be available in one of the centers as well, many centers as well, it might really have similar, which have a very advanced clearing or advanced suction methods that might helps actually to avoid any clogging of the tube as well. I'm reaching the conclusion, and by the way, I believe that when we talk about the ERAS or the ERACs, that's actually what I believe. It should be it definitely should be detailed, and at the same time should be very fast as well, because its time is of essence definitely, and time is important with that. But at the same time, the details actually should be emphasizing on the patient safety. So we are not really trying to facilitate the patient recovery, kick him out of the ITU, send him, escalate him to the HDU or to the ward in order just to clear the bed for another patient. No, it's not about the cost, it's not about the time. It's mainly about the patient safety. And because we know that the application of the ERAS or the ERACs will help with the patient ability to recover as soon as possible. That's why we should know from the beginning that it's complicated and yet promising target for the enhanced recovery. And although that those kind of challenges much really, let me say, overcome the need of the application of this protocol in a very particular way in many interventions. However, it's mainly standardized to be applied since the preoperative period, during the intraoperative, and finally in the post-operative period as well, in the form of the protocols that it might really be crucial and should be implemented to achieve the ERAS protocol in the cardiac surgery. The guidelines definitely, which been I think it's been modified and been altered for several times. It much really helps actually to provide a very, very good vehicle in order to achieve this target at the end. We should consider as well that the impact of having a COVID definitely have a very bad impact on most of our physicians, nurses, allied health workers. The need of ventilators, the ICU beds, the capacity of our ICUs, the changing of the ICU from one place to another in order to accommodate more COVID patients, the cost of application of nutrition and TBN and all BBE as well for our patient. However, this also will never be an obstacle against the application of the ERAS protocol in the cardiac surgery. Simply, this is the bundles and the preoperative and intraoperative and post-operative. It's very simple, actually. It's very so simple to retrieve. It's very simple, actually, to scroll it. And thank you very much. And thank you for all my dear speakers. Actually, it starts with a huge, let me say, achievement with how to treat the heart failure, how we can apply the ERAS in the non-cardiac surgery. And finally, thank you very much for allowing me to discuss the ERAS in the cardiac surgery. Thank you very much.
Thank you very much, Dr. Haytham. It's really, really fantastic, spot on. It's really interesting. It's really interesting to see how it's such right a really important ERAS programs being spread out to take most of the subspecialties and things like you saying, Dr. Haytham, like the cardiac surgery. It's really difficult, and I personally I never thought about some of the areas like the cardiac surgery and cardiothoracic and how we can nicely get involved with the expediting the patient recovery and and improving their ambulation and their pain management. And as you mentioned, with ERAS, it's really it's the same standard way, like Professor Medha mentioned. It's the same way, but how is artistically you are using this in a special way in your area of subspecialty, in orthopedic, in cesareans, and also obstetrics, and cardiac surgery, and vascular. It's really important. So, Dr. Haitham, just a simple question for me. What are you using for regional anesthesia for as a part of the ERAS in your center?
Well, to be honest, we don't use the regional anesthetics at all. I'm not saying that actually it's been resistible. I mean, but let me say that let me just take you slightly away from the cardiac surgery. For instance, I believe that even the thoracic surgery, even as well, it's not actually very familiar. Not all of the people are familiar to apply the ERAS protocol in the thoracic surgery. But
it is applied.
Yeah, currently, I was saying, currently it's been applied. I mean, initially it was difficult actually to be applied. Nobody knows how can we send the patient, I mean, away from the HDU while the patient having a huge thoracotomy wound, and the patient, how can we manage actually to be amputated as early as well? Currently, the patient comes on daily basis as a day surgery, stay in the short stay, and finally, with the use of the erector spinae block, which is became now one of the very famous nerve blocks, the patient actually the next day could actually manage to go home. So I believe that although that we were not really applying the use of nerve blocks in the cardiac surgery in some of the centers, because it is not really very popular. However, currently the application of the other protocols, keeping even the nurses aware about the use of the BCA and the prescription of medication, the combination of the drugs that might really helps to reduce the need of opioids, might really helps to facilitate the patient recovery and wheel him all the way from the ITU all the way to the ward immediately. And if the patient definitely with surgery, like the cardiac surgery, rather than staying for 2 weeks in the hospital, if you stayed like 2 or 4 days, definitely will be a very, very good achievement.
Yeah. Do you want to add anything, Dr. Medhat?
Yeah, I would like to explain something very important for everyone. When Henry Khalid started ERAS, I think I will ask Saad one time. I might in another week give a lecture about ERAS in general, because I think people should understand Henry Khalid is a very, I'm honored to be one of his close friends, and we go together to many places and we lecture in many countries all over the world. Henry Khalid, when he started ERAS, he asked himself a very simple question. He said, why if I have a car and this car, the tires worn off, I take the car, go to the mechanic, change the tire and drive it immediately and go out. In the same time, if I have somebody with a bad knee and he goes to the hospital to change the bad knee and put a new knee, he will stay in the hospital for 10 days or 1 week. Mm-hmm. This was the first question he asked himself to go to ERAS. He didn't started ERAS, he started fast track surgery. We have to remember that. So he started to study the pathophysiology, what things in our physiology which makes the recovery better and what things delay recovery. Mm-hmm. And he started then to think about the stress response, and he found at that time that mainly the things which delay recovery are the stress response issues. And the things which which enhance recovery is to minimize the stress response. So that was the idea. And actually, Henry Khalid is a professor of colorectal surgery, and he's the one who started fast track surgery. And then the society said that the word fast-track surgery give an impression that all his concern is speed. But no, let's call it enhanced recovery after surgery, because we are emphasizing that it's the quality which we are after, and this quality will lead to speed at the end. And he's a professor of colorectal surgery. He's the most famous doctor all over the world now, and they call him in the States the most famous anesthetist in the world, anesthesiologist in the world. Why? Because he thought about recovery. He thought what we should have been thinking, actually. So after that, it spreads in colorectal, and then it spreads everywhere. And in the UK, the task force and the consensus statement in 2012 was saying that ERAS protocol should be the normal, look at that, should be the normal in all patients undergoing major surgery. So the idea till 2012 was we apply ERAS for major surgery. When I started ERAS in the UK, when I was working in the UK long time, and then I came to the Gulf, and I found patient in recovery suffering from pain, from shivering, and I said, okay, the best way is to put this in a platform to change the practice of my colleagues who are still getting their patient out with hypothermia or shivering or pain. Okay, and then I said, ERAS is evidence-based, perioperative. So why only in major surgery? Ask yourself this question. If my son is coming for, I'm now a grandfather. My grandson is coming for adenoids or tonsillectomy. Do I want my son or my grandson to have shivering or to suffer from shivering or pain? No. So I started using it in my cesarean sections, because in the hospital I was working was a cesarean section, lots of cesarean sections. And actually I audited my work against my colleagues because they didn't do ERAS for cesarean section. I was doing ERAS. And I implemented every step of ERAS which is applicable to cesarean section, and I used it. And what happened? When they came, Henrik Kellet and Ole Ongvist, the ERAS Society president, when they came to the Dubai in 2015, when we had the first Middle East conference, I showed them the results. And then we started ERAS in cesarean section. And because I was the one who started it, they put me in the task force, and we published 3 papers, which are the Bible for ERAS in the American Journal of Obstetrics. So the idea is that, and this is my mission for all of you, is to implement whatever element of ERAS applicable to your patient. That's it. Because you mentioned, Haitham, one thing, that when we send the patient to the ICU and we want to do that, and we are not sticking, you know, like the idea is not to do ERAS or not to. I am allowing my patient to drink and to drink hot tea and coffee and the juice and the water in the recovery room, not because of ERAS, it's because it's evidence-based. They will improve the outcome. Yeah. And this will lead to improvement. So ERAS is using the evidence-based. It's not, I'm not fighting for ERAS to implement ERAS, fighting for evidence-based medicine. Don't stick with the old rules that the patient should be in bed. The patient should go to the theater on a trolley. Why? Yeah. Yeah. I'm a patient coming to do shoulder operation. Why I go to the theater in trolley? Nobody knows. When the surgeons write kneel by mouse for 4 hours post-operative, why he's writing that? If you ask him, he will say, I was trained like this. Yeah. His senior told him 4 hours. Somebody else will write 2 hours. No reason. no evidence. It's just dogmas. So try to analyze every step you do and what is the best evidence, and do the best evidence, and you will achieve ERAS. That's it. Thank you.
Thank you very much.
Fantastic, Dr. Medhat. I think we have also a raised hand from Dr. Safa. Does she want to add anything, or?
I think you want to say thank you so much for the excellent speakers tonight and the moderator.
Right, fine. Doctor.
And tonight is really very heavy scientific meal tonight, and all effort and dedication to accreditation to the excellent, eminent speakers tonight. Dr. Yasser, Prof. Medhat, Dr. Haytham, and the role model moderator tonight, Dr. Muhammad Mustafa.
Exactly.
The main energy behind this webinar tonight is actually to 130 colleagues attended from all over the world, from Australia, from New Zealand, from Far East, from India, from Pakistan, from America, from Canada. I know all of them geographically now, most thoroughly. And thank you very much. We achieved a very good success tonight by all of those distinguished speakers tonight. And fantastic topic. I think that's very hot topic, attracting a lot of people, changing the practice, and without, the most important, without moving an inch from your home, and without paying extra money to listen to all those fantastic speakers tonight. Thank you so much, and good night. Thank you.
Thank you. Good night.
Thank you very much.
You.
Thank you.
Thank you.
Bye.
Thank you.